Hi everyone, Dr. Obey Frimpong here again, and welcome back to the YouTube channel. It is TutorMed, where everything medicine is simplified. And so as promised, this video will feature part 2 of the pediatric history taking. We dealt with the part 1 where we looked at how to establish the reliability of a pediatric history, presenting complaint and its duration, history of presenting complaints, and then the ODQ. And so today we will continue with systemic inquiry onwards. And so if you have not seen our first video, kindly look at it before you look at today's video. If you are new here and you love what you are seeing already, kindly hit the like button, share this video, and then don't forget to hit the subscribe button, hit the notification bell so that you can be notified whenever we continue this lecture series. Alright friends, let's get started. ODQ done, the next is systemic inquiry. And so for systemic inquiry, you quickly run through the various systems of the child and ask questions to see if all systems are clear, as it were. And so for the cardiovascular system, again, be careful. Depending on the age of the child, you want to know whether the child feels the heartbeat whenever he is at rest, that is palpitations. You want to ask of chest pain, etc. For respiratory, you want to ask of cough, you want to ask of breathing difficulty. For gastrointestinal system, you want to ask for symptoms like diarrhea, constipation, abdominal pain. But again, these questions should be age appropriate. If the child cannot talk, you can't ask of abdominal pain. Okay, then you can ask about ENT, I mean eye or ear, nose and throat. That is the word, or that is the meaning. You ask for ear discharge, nasal discharge, any ear pain, any ear tagging, etc. And so the systemic inquiry, as you know by now, just skims through the various systems, asking for problems or asking if the systems are clear. So that is the systemic inquiry. Right. And so from the systemic inquiry, we move to the past medical and surgical history. And so here, you want to know if there are any chronic medical conditions. But notice that you've asked that question previously in the HPC. And so you go on to ask if there are any past surgical procedures done, whether the child has had any surgeries done in the past. You also want to know if there are any previous admissions. It doesn't have to be a chronic medical condition, but whether the child has been admitted before on account of a condition. If that is a positive answer, you want to know when the child was admitted, on what account the child was admitted, and how long the child spent in the hospital, and whether or not the child was discharged in a stable state. Also, you want to know if there are any previous blood transfusions. And so these are the very few things you want to know in the past medical and surgical history. And so friends, please do not forget to like and share this video and subscribe to our channel if you haven't done that yet. From the past medical and surgical history, the next step is the drug and allergic history. And so here, you want to ask the mother or the child if the child is on any drug or any medication for some reason. You want to know if the child is being given any oral herbal preparations or herbal preparations of any kind. You want to know if the mother gets over-the-counter medications for the child. Then for allergy history or allergic history, you want to know if the child reacts to anything in the environment, whether it is a drug side effect or it is food allergy or anything. You want to know whether it is perfume or pollen, dust. You want to know whether the child has any allergic history. The next step is the prenatal, birth, and if the child is a bit older, the neonatal history. So you want to know what happened intrauterine, during birth, and then during the neonatal period. That is if the child is out of the neonatal period. And so 3 sections. Let's look at the questions to ask here. And so for this aspect, the first thing you want to know is whether the conception was natural or via an assisted reproductive technique. Then you want to know if the pregnancy was planned and welcome, or maybe it wasn't planned but it was welcome, or maybe it was unplanned and not welcome. Once you get the third answer, you have an idea that the contribution towards this child's well-being may be questionable. Then you want to know how the pregnancy was confirmed. Again, You want to know when booking was done. Remember, we said in our ONG lecture that booking visits is the first time the woman visits the antenatal clinic when she's pregnant, and whether she was a regular attendant at the ANC. If yes, where was she attending her visits or her clinics? Then you want to know when was quickening. In other words, when did the baby start to move? Another thing you are interested in the prenatal history is, was there any pre-pregnancy medical condition on the part of the mother? And she did her ANC labs. Were there any abnormal findings in her routine ANC labs? For example, how was her booking hemoglobin content? What is her blood group? Particularly very important in neonates who are jaundiced. What's her sickling status? What was her VDRL report or result? What was her retro screen result? And what was her G6PD status? Then you want to know whether the pregnancy was complicated by any medical condition or obstetric complication. Like, did she have hypertension in pregnancy? Did she have diabetes in pregnancy? Did she have prolonged PROM or prolonged rupture of membranes? Did she have maybe maternal chorioamnionitis? All those things. Then you want to know whether the mother got her anti-tetanus prophylaxis appropriately, and whether the mother took any unprescribed medication or used any substance during pregnancy, including alcohol or cigarette smoking. And was there any perinatal febrile illness? All these are important. So that is for the prenatal history. Then we come to the delivery history or the birth history. We want to know at what gestational age was the baby delivered. Was it delivered at term, preterm, or postterm? You want to know that? Then you want to know where and how the baby was delivered. How the baby was delivered. Was it vaginal delivery? If that is the case, was it spontaneous or the baby or the labor had to be induced? If there was induction of labor, what was the indication for the induction of labor? If the baby was delivered via cesarean delivery, you want to know whether it was an emergency cesarean delivery or an elective cesarean delivery. In either case, what was the indication for the cesarean delivery, whether emergency or elective? Now, if the mother had labor or delivered via vaginally, I wanted to say, you want to know how long did the labor last and what was the presentation of the baby. Was the baby breech, or the baby was cephalic, or the baby came with a shoulder? What was it? All these are very important. Now, after the baby was delivered, whether via vaginal delivery or cesarean delivery, did the baby cry right after birth? You want to know that? And then what were the Apgar score for the baby at 1 minute and then 5 minutes after birth? What was the baby's birth weight? You want to know that, very important. And then, did the baby need any form of resuscitation after birth? You will also want to know that. You want to know when meconium was passed. Was she told that the meconium or the liquor was stained with a green substance or not? If the liquor wasn't stained with any green substance, you want to know when the baby first passed stool, that is his meconium. You want to know whether the baby required NICU admission right after birth. And if that is so, what was the reason for the NICU admission? You want to know how many days the baby stayed in the facility. If the mother stayed, let's say, in the facility for 3 days, you want to know whether it was a maternal or an obstetric problem or it was a neonatal problem. If it was a neonatal problem, you need to find out what the problem was. And then lastly, you summarize by asking if there were any problems in the neonatal period, like jaundice, difficulty breathing, etc. Very good. Now you see I have given an extensive history on the prenatal, birth, and then neonatal history. Now, it is not, you don't take this detailed history for every pediatric patient. No. That is why it is very important to establish or know the patient classification. For example, if you are dealing with an infant or a neonate, or let's say a baby, you may have to go through this detailed prenatal, birth, and then neonatal history. You need to go into details. Or for example, if your patient, despite the age, came with, say, a complaint of inability to walk, maybe even at age 3 or so, you want to take a detailed prenatal and then birth history, because you know that maybe the inability to walk or the delayed developmental milestone could be because of a birth problem. So you need to take a detailed history. So that's an exception. But if you are dealing with a much older child and then his presenting complaint has nothing to do with the prenatal, birth, and neonatal history, you don't have to go through the extensive history I have given. You can just ask the mother, how was the baby conceived, right? And then you ask whether the antenatal period was eventful. Was there any event or any problem during the prenatal period? Then of course you want to find out how the baby was delivered, at what gestational age the baby was delivered, and then whether there were any delivery problems. You can just summarize it and then ask whether there were any neonatal problems. And so for a much older child, you may not have to go through an extensive birth history or pregnancy history, unless of course his presenting complaint requires that you detail the birth history. Like I said, cerebral palsy, you may want to find out whether there was any birth injury, birth insult, okay? If the child comes with Erb's palsy, for example, you cannot just skip there or make a run through the birth history. You would have to go into details and then see if there was any injury or insult at birth. But aside that, you take a detailed birth history if you are dealing with a child. If you are dealing with a neonate or a small infant. Very good. Are you liking what we are doing? If the answer is yes, please don't forget to leave us a like, share the video, and subscribe to our channel. Hit your notification bell so that when we deliver or when we upload new videos like this, you can have access to them quickly. And so the next step is the immunization history, another aspect of the pediatric history that is different from the adult history. And so again, here in the immunization history, depending on the child's age, you may have to do a little work or you may have to do an extensive work. For example, if you are taking the immunization history of a neonate, say a 4-day-old neonate, you would agree with me that you don't have to do much work. All you need to ask is if the child has had his oral polio vaccine 0, he has had his BCG vaccination, or he's had his Hep B vaccine at birth. That is all you need to do. Whereas if the child is, much older, you may have to go through the immunization history a bit into details. Now, I have made a video on how to memorize the immunization schedule in Ghana using a story. I'm sure most of us have seen that video. If you are new to that video, I'll leave the link below. Kindly have a look at them so that you don't miss out. Now, here in this part of the history, this is the only point you are allowed to do inspection whilst you are taking a history. So sometimes, if the mother claims that the child has had, for example, the BCG vaccination, you are allowed to check the right deltoid. Okay, the lateral aspect of the right deltoid, looking for the BCG scar, and then confirming with your eyes that indeed the child has had his vaccination. Remember that not all people or not everyone has the BCG scar, and so the fact that you don't see the BCG scar does not refute the fact that the mother actually is speaking the truth of a child having the vaccination. Again, this is the only point in time you can take the child health record book. So at this point in time, if the mother tells you that the immunizations are up to date, you quickly ask her if she brought the child health record book. Now they have been, added together, maternal and child health record book. So once she brings it out, you'd have to open to the immunization section and then confirm if the child's immunizations are up to date. So here you just summarize and say that the mother said the child's immunizations are up to date. BCG scar was seen at the right deltoid, and on inspection of the maternal child health record, I saw that the immunizations were up to date. Done. You are done with the immunization history. Yes. And so the next thing I would want, or the next aspect I would want to talk about, is the nutritional history. Now, this aspect of the history evaluates or assesses the child's nutritional status, whether the child is eating well, whether the child is well nourished or undernourished or overnourished, as it were. And so here, again, it really depends on the age of the child. For example, if you are dealing with a neonate, you would want to take a detailed breastfeeding history. If you are dealing with a much older child, you would want to take a little of a breastfeeding history and then focus on the adult foods he's been eating. If you are dealing, and again, as probably you have taken note of, if the child's presenting complaint has something to do with malnutrition, then you really have to focus on the nutrition history very, 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 very well. Like I gave an example, if the child's presenting complaint would have to do with his developmental milestone, you'd have to focus on the development very, very well, the developmental history very well. And so I'm saying that if the child's history or presenting complaint has to do with anything nutrition, you'd have to take a very good nutritional history here. And so the nutritional history here, depending on the age of the child or depending on the presenting complaint of the child, you may have to take a detailed breastfeeding history, a detailed adult food history. And so let's look at how to take a good nutritional history. And then your job here, after taking the nutritional history, is to establish whether the nutrition is adequate for the child or inadequate for the child. So after you've taken the history, your conclusion, is it adequate for the child or inadequate for the child? And so let's see how to take the nutritional history, showing the whiteboard. And so the nutritional history, like I said, you want to know whether it is appropriate and adequate. So you want to begin by asking when breastfeeding was started, especially when you are dealing with a neonate. When was breastfeeding started? Ideally, right after delivery, the baby can feed whenever the mother or the baby wishes to. There is no specified time. So you want to know when the breastfeeding was started. You want to know how many times a day does the baby breastfeed. The baby is supposed to breastfeed about 8 to 12 times a day. That is very good. And then you want to know how long does the baby sleep in between meals. The baby here, I'm not sure of any agreed time the baby should sleep in between meals, but the baby should be waking up often to feed. The baby doesn't have to be sleeping a lot of the times. Then you want to know whether the baby has any fatigue or difficulty breathing when the baby feeds. If that is the case, you may suspect maybe a congenital heart condition which is causing heart failure, because one of the symptoms of heart failure in neonates is the fact that the baby has fatigue during feeding. You want to know whether the mother breastfeeds the baby on demand. Okay, so if the baby cries, the mother breastfeeds, or the mother waits for some time before she does it at her own convenience. Or sometimes if the mother breastfeeds on demand, it could be that the baby is sleeping, or for a sleeping baby, for a sleeping baby, if the mother breastfeeds on demand, and it means that if the baby just demands for 4 times, the mother feeds for 4 times, and that will not be enough for the baby. And so you want to find out if the mother breastfeeds on demand, how demanding is the baby's, how often does the baby demand for feeds? Then you want to know if the baby is able to empty one breast completely before moving to the other breast. Then for a baby or an infant who is past 6 months, you want to know, and then other older children, you want to know whether the baby or the mother did exclusive breastfeeding, that is, giving only breast milk for the first 6 months without adding anything, not even water. You want to know that. Then you want to assess, that is appropriateness. Now you want to assess the adequacy of the breastfeeding or the nutrition. And so you can do that by counting the daily diaper change. Okay? And so although this is not universal, whenever the baby wets the diaper at least 6 diapers per day, it is assumed that the nutrition is a bit adequate. Or when the baby soils up the diaper at least 4 diapers, passes feces per day, it is assumed that the nutrition is adequate. Then here again, you are allowed to check the child health record book for weight pattern. So you want to see how the weight gain pattern or the weight loss pattern has been. It is sometimes plotted in the child health record book. Then you want to know when and with what was complementary feeding started. So if the complementary feed was started, when was it started? Ideally, it should be above or after 6 months. And then what was used for the complementary feeding? You'd want to know this, and then you want to know how often the baby eats that complementary food. Then you want to know at what age the baby was fully weaned. Weaning is cutting off the baby's, cutting off the breast milk from the baby completely. So you want to know when was that, or when that was done. That is the breastfeeding history. Good. And so for an older child, you may want to know whether exclusive breastfeeding was done, and then you want to know when complementary feeds was started, and then when weaning was fully, instituted. Then you come to the adult feeds for, an older patient. Here you would want to use various tools. The tool I like to use when I was a student was the 24-hour dietary call. And so you want to know immediately before the child fell sick, can you recall what the child ate in the morning, in the afternoon, and then in the evening? Or if you don't want to use the 24-hour dietary recall, you would want to ask the mother about the food the child usually takes. Okay, the food the child usually takes in the morning, in the afternoon, and the evening. And so whether you are using the 24-hour dietary recall or the usual foods the child take, you can start like this. In the morning, what does the child eat? For example, they will tell you that the child eats maybe maize porridge and then bread. Then you want to go ahead and then quantify it. Can you quantify the amount of maybe maize porridge she takes? If there is a Voltic bottle, you can just ask her to compare the amount she takes with a Voltic bottle. Then maybe she says, half of a 500 ml Voltic bottle. Then you have an idea that that's a 250 ml maize porridge she takes. Then you want to go ahead. So the bread, can you estimate the size of the bread? Is it like the fist of your hand? The one says, a little more than the fist of my hand. Then you have an idea. They want to know whether there is any spread in the bread, whether it comes with fried egg or it comes with any salad or any margarine or any groundnut paste. You want to know that. If the mother says that the child takes in tea, you want to know which type. Is it Milo? How many spoons of Milo does she use? How many tins of milk? How many teaspoons full of milk? You want to do all this to assess the adequacy and appropriateness of the feed. Then you come to the afternoon. So what does the child eat in the afternoon? Mother tells you that, usually she eats or he eats maybe a plate of rice and then tomato stew or vegetable stew with 1 egg. Then you want to quantify the plate of rice. How many ladles of rice do you give? The mother says, usually I take like 3 ladles of rice. Okay. And then what do you use in preparing your vegetable stew? She gives you a bit of the ingredients, then you know the protein the child takes, then you're okay with it. You go to the evening. So in the evening, what does the child usually take, or what did she take before this current illness? They tell you that she usually takes a bowl of banku with maybe okra soup and then fish. You say, okay, fine. So can you estimate the size of the bowl of banku? Again, you can use your fist. Is it like the fist of my hand? The mother says, it's a little less than the fist. Okay, then you have an idea. And then how many ladles of soup? You want to know that. And then what's the size of the fish? Is it like 2 fingers, like my fingers, or like the fist of my hand? Then you have an idea. So the whole point is to try and have an idea of the quantity, quantify it to know the appropriateness and the adequacy. You are not done with that. Once you have established the breakfast, the lunch, and then the supper or dinner, you'd want to know whether the child takes in any snacks in between meals. So if the child takes in snacks, you want to know the type of snacks, biscuits or maybe some fizzy drinks. All of these have to feature in your history. Then you want to know if the child takes in fruits. So what kind of fruits does the child like, for example? Then you want to know if it's banana, how many fingers of banana? If it's oranges, how many oranges? If it's mango, how many mangoes? Remember that the pediatric discipline is a very inquisitive discipline. It really takes note of petty things. In my opinion, pediatricians are the most inquisitive, most meticulous group of medical doctors, and so we need to take this detailed history when you are dealing with a child, particularly if the child comes in malnourished. After that one, you have to take these detailed histories. And then remember that at the end of all these, your judgment is, you're asking yourself, is the nutrition adequate or inadequate? That is your judgment for the nutritional history. The next aspect of the history I would want to talk about is the developmental history. Now, in this part of the history, it depends. It really depends on what you are doing. For example, if you have a patient, an older patient, who comes to you and then you think that the patient has cerebral palsy, you really have to go into details when it comes to this developmental history. Or the patient has autism, you are suspecting autism, you really have to go into details. However, the general rule is that for developmental history, if the child, you don't think the child has a developmental problem, and then you get to this point, the child is an older child, let's say a 9-year-old child, you want to just say something about the developmental history, you just want to know what the child can do now. So you ask the mother, what can your child do now? Mother tells you that, the child can run errands, the child is actually can communicate effectively, the child has friends, the child is 9 years old and he's in class 5. He is doing so well such that his position in class at the end of the term is second out of 45 students. Then you are okay with the developmental history. The developmental history is appropriate for age. That is it. It is appropriate for age. However, if you are dealing with a younger child, you may want to go through the developmental history into details. Okay, and so for the developmental history, we have about 4 main areas for developmental history. The first area is called the gross motor. Then the next area is the fine motor and vision. Of course, to be able to perform some fine motor skills, you need your eyes to be able to perform them. And so the first is gross motor, and then fine motor and vision. They are in one basket. Then the next is language and hearing. And so to be able to speak fluently, you need to have heard something. Okay, and so if you have a problem with your hearing, your language acquisition skills would be a problem. And so that's the next area. That is language and then hearing. Then the last area is social interaction. Okay, so the 4 main categories, I'm going through them again: gross motor, fine motor and vision, and then language and hearing, and then social interaction or the social development. And so you want to assess the child under these 4 main developmental milestones. And if the child has a delayed milestone throughout these 4 categories, you see the child has a global developmental delay. And so let's look at these 4 developmental areas. But again, I want to stress on the point that if your child or if the patient is much older, you don't have to go through all these. You may have to ask the parents what the child can do now, and if it is appropriate for age, you can just see that the child has an appropriate developmental milestone acquisition. And so let's look at the 4 areas now. And so the first area we want to talk about is the gross motor. Gross motor, and this is a picture I got from Illustrated Clinical Science, sometimes called Lizer. This is one of the recommended books in University of Ghana Medical School for Pediatrics. And so the gross motor, we are looking at head control, as you can see on the screen. The time the child attains head control should be about 4 months. Now you can see limit age here. It means that the child should be able to achieve head control by 4 months of age, although this does not work for every child, but for most children, they should attain head control at 4 months. Then the child should be able to sit unsupported at 9 months. Then the child should be able to sit supported at 6 months. So at 6 months, you're supposed to sit supported, maybe by a chair, but to be able to sit unsupported, by 9 months, the child should be able to achieve that. then the child should be able to stand independently by 12 months of age. Then the child should be able to walk independently by 18 months, that is 1.5 years. Kindly note that some children do not go through this, as I've said. Some children are what we call bottom shufflers, so they shuffle with their bottom before they get up and then walk. Some children are also commando crawlers, that is the picture I have shown, but please take note of the gross motor developmental milestones. And so you ask the mother, at what point was your child able to control the head? At what point was he able to sit with support and without support? What was the child's age when he was able to stand independently without holding anything? And how old was he when he was able to walk independently? Sometimes the mothers may forget. I mean, not everybody can keep all these information in the head, so it is okay if they can't remember. Then we move to the vision and fine motor. That is the screen there. And then this picture again I got from Lisa. You want to know at what age that did the child, or was the child able to fix his eyes on an object and then follow it visually? And then at what age was he able to reach out for objects? You want to know that. At what age was the child able to transfer objects, maybe from the left hand to the right hand? And you can see the limit ages there. And at what age was the child able to perform pincer grip? And that is a picture of a pincer grip. And the age limit is 12 months. We move to hearing, speech, and then language. You want to know at what age was the child able to make some polysyllabic babble? That is the limit age there. Then at what age was the child able to make some consonant babble? That is the limit age of 10 months. And at what age was the child able to say at least 6 words which makes meaning or comprehensively? That is at the age of 18 months. Okay, so all these should be asked, but again remember, the mother might not be able to, remember the exact ages, but it is worth asking. Then for the social behavior, you want to know at what age was the child able to smile back at the mother when the mother smiled at the child, and that should be at 6 weeks. And then you can see the others: fear of strangers at 18 months, etc. Now here again, you want to know whether the child has friends or not, and then that the child play with other children of her age. You want to know that because some of these things, if they are not there, might suggest that the child probably has an autistic spectrum disorder. So you need to do that. And so that is the developmental history. After assessing all these, you want to know if the history is appropriate for age, or the milestone attainment is appropriate for age, or is not appropriate for age. Good. And so if our patient is an adolescent female, we cannot conclude a pediatric history without asking for a basic gyne history. And so for the basic gyne history, we just want to know when the child or the female child began her menses. That's a menarche, so the age at menarche. We want to know how many days she bleeds for, so the duration of her menstrual flow, and we want to know the regularity of her cycle, her menstrual cycle, and of course we want to know her menstrual length. And so these are the things we want to know. Of course, we also want to know if the child is sexually active. Now, if you are taking this history for a child, asking about whether or not she's sexually active, at this point, you may have to ask the parents to excuse you because of patient confidentiality. Sometimes, if the parents are around, the child might not volunteer this information. So at this point, you may want to make sure that the child has enough enabling environment to give you what you want. And so you also want to know if the child is sexually active or not. You want to know if there is a history of contraceptive use. All these are very important. Asking the child, especially when she comes with a presenting complaint which requires that you go down that line. But I'm saying that remember that if the parents are there or if the caregivers are there, they are not likely to give you the correct answers. And so you need to make them excuse you for you to take that history. Are you liking what you are doing? If you are loving it, kindly remember to like the video, share the video, and subscribe to our channel. Support us, it means a lot to us. Alright, and so here I want to talk about the social history. Now, social history, I like to think of social history as the 4 determinants of health. I've mentioned them already. Okay, according to epidemiology, we have about 4 determinants of health, which have been summarized into the 4 H's. Okay, so the habitat where the child lives, the heredity, the family the child comes from, whether it impacts the child's health, then the habit, what the child does, the lifestyle, and then the health and health system. So these are the 4 H's that determines a child's health. So that's the social history. The social history will be composed of the habitat, the habits, and then the health systems. And as we'll see later, family history will take care of the heredity. Now, what goes on in the social history? For the social history, we are interested in where the child stays and then who the child stays with. Does the child stay with the mother and father? Are they married? Once they are not married, then we are questioning, so the contribution as far as the child's well-being is concerned, how is it going? Because this is social pediatrics. There are a lot of social issues in pediatrics. So we want to know whether the child's parents are married or divorced, or whether the child is a child of just a single parent, because all these will have an impact on the child's well-being. Then you want to know, well, the mother. Let's assume that this child stays with the mother and father and they are married. You want to know where they stay, maybe at Dansoman, in their own house or in a compound house. You want to know all these. Then the mother, you want to know whether the mother smokes cigarettes or whether the mother takes in alcohol. Okay, then you want to know the level of education of the mother. You want to know the occupation of the mother. And how much the mother earns at the end of the month. Typically, you wouldn't ask these in adult history, but in pediatric history, this is very important because you want to know how much is coming into the child or how much is going into the child's care. So you want to be a little inquisitive, but when you're asking this, you'd have to be very polite, very diplomatic in asking how much the mother earns. You do the same for the father. Does the father take in alcohol? Does the father smoke cigarettes? What is the occupation of the father? How much does the father earn at the end of the month? And then you want to know, you want to know all these things. And then still on the father, you want to know you want to know how much the father contributes to the child's well-being. Very important. How much does the father contribute to the child's well-being? Again, you want to know whether the father has any children outside of the marriage. Okay, and the mother has any children outside of the marriage. You want to know all these things. Again, in social history, you want to know the age of the child's immediate older sibling. Because there is one problem called sibling rivalry. That sometimes if the child has a relatively younger, older sibling, immediate sibling, and then the child comes into the picture, the mother might pay attention to the child more than this immediate older sibling who is also younger. And so because of that, there might be sibling rivalry, and then there is a risk that this immediate older sibling might harm the child because he or she is not getting the attention he used to get before the child came. So he might feel that the child has come to take the mother's attention away from him. And so there is a risk of sibling rivalry. You want to know that. Again, you want to know the room that the child sleeps in. How many windows are in the room? And then how are they positioned? Are they positioned adjacent or opposite? You want to know the ventilation in the room. Okay? You would want to know how many people sleep in the room the child sleeps in. You want to know the source of drinking water for the child, the source of cooking water for the child, who cooks the child's food, and what is the fuel used in cooking at home. If it is a smoke-producing fuel, a lot of it like charcoal, firewood, if the child comes with recurrent respiratory infections, you are not surprised, or recurrent respiratory symptoms, you are not surprised, right? So you need to know that. Again, you want to know if the child has been admitted. You want to know, ever since the child was admitted, how many times has the father come to visit the child? Very important, because there are a lot of social issues in pediatrics. And again, if the primary caregiver is actually the father, or you come to the child always, you see the father around, you should be inquisitive. Where is this child's mother? Are there any problems? You want to know all these things. And then if the child has a chronic medical condition, you want to ask the mother, how has the chronic medical condition affected your marriage? Has the father run away? Because a lot of the times, particularly for children, in my practice, when I was a house officer in Kolebu, there were a lot of single mothers because their children had sickle cell disease, HB, genotype SS, and always the child had to be admitted. And because of that, it had impacted on the marriage, said that now they are divorced because the man feels he's spending a lot on the child, and so he wants to move out of the marriage. Good. And so again, in the social history, you want to know whether the child is on health insurance and whether it is active or not. If the child is not so old, maybe a neonate, you may want to know whether the mother is on health insurance and whether it is active. You want to know the religion. Are they Christians? Are they Muslims? What religion do they practice? You also want to know where the child comes from. The hometown, the ancestry. If the child comes from a place where probably eating of eggs, for example, is a taboo, then you can be sure that this child, the child presenting with kwashiorkor for some reason, it's not surprising. Okay, then you want to know whether they accept blood transfusions. You want to know that as well. So these are the few things you want to know in the social history. Now, although I seem to have given a lot of information, when you are writing or when you are taking a pediatric OSCE history taken in pediatric OSCE, you wouldn't go through all these. But I'm saying this for someone who is on the ward, who is supposed to take a detailed pediatric history. You'd have to go through all these and be inquisitive as much as possible to be able to dig out a lot of information to care for the child. Very good. And so we come to the last part of the pediatric history, which is the family history. And so for the family history, like I said, you want to know the impact of heredity as a determinant of health on the child's health. So you want to know whether there is any chronic medical condition that runs in the family. Is there a history of hypertension, diabetes, sickle cell disease? Is there a history of epilepsy in the family? You would also want to know if the siblings of the child are alive and well. You want to know how many siblings that the child have, and then the child is number what out of the siblings. Maybe the child is number 2, the child is number 3 out of maybe 3 children, the child is number 1, first out of 4 children. You want to know that. Then you want to know if there is a history of consanguinity. Now, this is an aspect of pediatric history that is so unique and very important. You cannot finish taking a pediatric history, without asking for consanguinity. Of course, you wouldn't ask the mother that, oh, please, madam, is there a history of consanguinity? No, that is not how the question should be put. Now, in asking this question, you also have to be very diplomatic and very polite. You want to ask, madam, please, is it possible that you and your husband share a common blood relation? Or are you related to your husband in any way? Any family ties? Then the woman might seem confused. Then you go ahead further and you explain to her that the reason why I'm asking this is because there are some conditions which are very common in children whose parents are related by blood. And it's very important you give me that information to help manage your child. And so please do not feel offended if I ask you. So again, I'm asking you, are you by any chance related to your husband by blood in any way? Some people marry their cousins, some people marry their uncles, some people marry their nieces. And like I said, there are some congenital or some genetic syndromes that runs through children with a history of consanguinity. So consanguinity is, a marriage between two people who are related by blood, and then their children will suffer some conditions, and so you need to establish that as well. And so this brings us to the end of pediatric history taking. I trust that this helped a lot, and then please support us by liking and sharing the video, subscribe to our channel, and then very important thing to do is to hit your notification bell so that you do not get left out when we post new videos. And so I will see you in the next lecture. Until then, bye.